initial evaluation and algorithms, penetrating thoracic injuries, blunt thoracic injuries, and essential thoracic procedures. Let's dive right in. Section 1. Initial evaluation and algorithms. Okay, so the golden rule of advanced trauma life support, or ATLS, is absolute here. Every hemodynamically stable patient with suspected thoracic trauma gets plain chest radiography immediately following the primary survey. No exceptions. Your initial chest X-ray findings, specifically the presence and size of a hemothorax or a pneumothorax, well, they dictate your entire roadmap. For most clinically stable patients, we're going to place a 32 to 36 French chest tube. But notice the red pathway on this algorithm. We head straight to the operating room for a thoracotomy if that initial tube output is greater than 1,500 milliliters, or if the output is greater than 200 milliliters per hour over the next 2 to 3 hours. That is a hard, high-yield threshold you've got to commit to memory.
Moving right along to Section 2, penetrating thoracic injuries. Now, while penetrating trauma is actually less common than blunt thoracic trauma, it is vastly more deadly. Up to 30% of all penetrating chest injury patients will end up requiring a thoracotomy.
Let's break down a classic penetrating injury, the open pneumothorax. The pathophysiology here is critical to understand. This happens when a chest wall defect is greater than or equal to 2/3 the circumference of the trachea. Because the wound provides less resistance to airflow than the patient's own trachea, air is preferentially entrained right into the pleural space during inspiration. That's what creates that classic sucking chest wound. So what's the immediate temporizing fix in the field before definitive operative repair? It's a 3-sided occlusive dressing. This is a brilliant little maneuver because it creates a flap valve effect, allowing trapped air to escape during expiration, but sealing shut to prevent any more air from entering during inspiration.
These radiographs brilliantly illustrate what happens when that air gets trapped and just pressurizes. In a tension pneumothorax, you can clearly see the deviated trachea, the visibly displaced mediastinum, shifting entirely away from the injury, and that severely depressed ipsilateral hemidiaphragm. But remember, tension pneumothorax is a clinical diagnosis first and foremost. It rapidly leads to obstructive shock by collapsing venous return to the heart. You literally cannot wait for an X-ray if the patient is unstable.
So the absolutely crucial point is identifying the clinical signs immediately in the trauma bay. You want to fire through these key vitals: tachycardia, hypotension that is completely refractory to fluid resuscitation, a hyperexpanded chest with decreased excursion, absent breath sounds on the affected side, and an increased central venous pressure. If you see this constellation of signs, immediate decompression is mandatory. Don't wait for the 32 French chest tube. You immediately insert a large-bore angiocatheter in the second intercostal space at the midclavicular line to temporize the patient. Now, penetrating trauma to the heart itself is another highly lethal scenario. Because of its anterior position right there in the chest cavity, the right ventricle is the most frequently injured chamber. These injuries rapidly cause obstructive shock via cardiac tamponade. The pericardial sac has incredibly poor compliance. Just 50 milliliters of acute blood accumulation is enough to cause a lethal tamponade. You're going to recognize this clinically by Beck's triad: distended neck veins, diminished heart sounds, and profound hypotension. So, what's the operative approach? Well, if you have a hemodynamically unstable patient with a suspected penetrating mediastinal injury, the preferred move is a median sternotomy. This gives you prime, rapid access to the proximal aorta, superior vena cava, and the heart. However, if you identify or even suspect an injury to the left subclavian artery, you're going to need to utilize a supraclavicular or trapdoor extension off that median sternotomy to get proper exposure. During the actual cardiac repair, notice how the surgeon uses interrupted monofilament horizontal mattress sutures. The absolute key takeaway here is that these sutures must pass strategically beneath the coronary arteries. If you throw a stitch over the artery, you're going to ligate it and cause secondary iatrogenic myocardial ischemia, and we definitely don't want that. To round out penetrating injuries, we've got to consider the aerodigestive tract. These injuries demand a remarkably high index of suspicion from you because they're so often occult. If you feel subcutaneous emphysema on physical exam, alarm bells should be ringing in your head. For tracheobronchial injuries, your very first priority is stabilizing the airway, followed right up by fiber optic bronchoscopy to locate the defect. Esophageal injuries, they're equally terrifying, mostly because a misdiagnosis leads to highly lethal secondary mediastinitis. You absolutely must evaluate this promptly using esophagoscopy or esophagography with an aqueous contrast followed by barium.
All right, Section 3, blunt thoracic injuries. This category alone directly accounts for 20 to 25% of all trauma-related deaths, and it is predominantly driven by motor vehicle collisions.
One of the most significant blunt chest wall injuries you'll see is the flail chest. This happens when extreme stress fractures multiple adjacent ribs in multiple places. That entire segment essentially detaches and moves independently from the rest of the chest wall during respiration. But here's the critical clinical pearl for you. The broken ribs aren't actually what kills the patient. It's the underlying pulmonary contusion that drives the severe respiratory compromise. The crucial management step here is aggressively placing early epidural catheters for pain control. That allows for robust pulmonary hygiene and helps prevent subsequent respiratory failure or pneumonia down the line. Next up is blunt cardiac injury, or BCI, which accounts for up to 20% of MVC deaths. Just like with penetrating trauma, the anterior impact most frequently damages the right atrium and right ventricle. But I really want to aggressively drill this exam-relevant point into your mind. The absolute first diagnostic move for any patient with suspected BCI is a 12-lead EKG. Not an echo, not troponins first, the EKG is always step one.
Checking out the EAST guidelines for BCI evaluation, we get an incredibly high-yield fact. If a patient has a strictly normal admission EKG and a normal troponin I level, you have completely ruled out blunt cardiac injury. Further pursuit of the diagnosis should just be abandoned. Also, take a look at level 3. The mere presence of a sternal fracture does not predict BCI on its own.
Perhaps the single most devastating blunt injury is to the thoracic aorta. Blunt aortic injury carries an 80 to 90% pre-hospital mortality rate. The rapid acceleration-deceleration forces typically tear the aorta at its most fixed anatomic point, which is the ligamentum arteriosum, right at the takeoff of the left subclavian artery. If the patient survives to the trauma bay, they likely have a partial tear. Your gold standard diagnostic tool here is CT angiography, which boasts a 97 to 100% sensitivity. The absolute necessity before prompt surgical or endovascular repair: strict, aggressive blood pressure control to prevent that partial tear from completing.
Finally, Section 4. Essential thoracic procedures. These are the definitive, life-saving interventions every trauma provider must know cold.
First up is VATS, or Video-Assisted Thoracoscopic Surgery. It's a minimally invasive technique using ports and camera, very similar to laparoscopy. The high-yield takeaway here is the timing. Early use of VATS, specifically 3 to 7 days post-injury, to manage a retained hemothorax, persistent air leak, or early empyema, drastically decreases complication rates and significantly shortens hospital lengths of stay for both our blunt and penetrating trauma patients. And lastly, the absolute last resort for a patient arriving in extremis, the resuscitative thoracotomy. Let's rapidly walk through the sequence. First, you make a left anterolateral incision in the 5th or 6th intercostal space. Step 2 is the pericardiotomy. And guys, this harbors a classic exam pitfall. You must incise the pericardium vertically anterior to the phrenic nerve to avoid accidentally transecting it. Once you're open, you perform cardiorrhaphy to close the wound, evacuate air via needle aspiration, and institute open cardiac massage or place a descending aortic cross-clamp to maintain cerebral and coronary perfusion. Okay, we've covered the algorithms, the distinct pathways for blunt versus penetrating injuries, and the exact steps to save a life in the trauma bay. Now I want to leave you with a direct challenge to test your attention. A 34-year-old male is brought to the ED after a gunshot wound to the right chest. He presents with a heart rate of 125, a systolic blood pressure of 80, his trachea is deviated to the left, and he has absent breath sounds on the right. What is the absolutely critical first step in management? Think about the clinical diagnosis and the temporizing intervention we just talked about. Thank you for joining this rapid revision explainer. Keep analyzing the material and stay sharp out there.